Cancer of large intestine is a very common problem, especially in developing countries. Large intestine is known as colon. The first 6 feet of the large intestine are called colon, and the last 6 inches is called rectum or anus. Anus is connected to anal opening from which the feces are passed. Today we will talk about a very common condition called cancer of the colon. Let us look at the risk factors. People have some hereditary predisposition to rectal and colon cancer. Polyps, which are small growth in the inner lining of the large intestine or colon, can also become cancerous. They are called adenomatous polyps. Ulcerative colitis, which is another common condition where the whole of the large intestine is filled with small ulcers, and they over a period of time, if not treated well, become cancerous. Every 10 years, the risk of ulcerative colitis changing into cancer is around 1%, and at 20 years it becomes roughly 2%. And we have very common condition, ulcerative colitis, which is prevalent in society. It needs to be treated well and kept under control. Let us look at the anatomy of the colon. This is the right side of the colon. This is the transverse colon because it lies transversely in the body. This is the left colon. This is sigmoid colon. If you see this loop, it is called sigmoid colon, and this portion is called rectum. The last 2 inches of the portion is called anal canal. So this is the anatomy of the colon. Now let's come at the signs and symptoms of colon cancer. The commonest sign which one sees and symptom which one feels in the colon cancer is pain abdomen, bleeding in the stools. Though the causes of the bleeding in the stools are many, cancer is one of them. That is why whenever there is a bleeding from the stool, it should not be ignored, it should be investigated. However, as I said, that bleeding can be from many sources which are not cancers. Like piles is a very simple cause of the bleeding, but it needs to be attended to and investigated. Another common symptom is pain in the abdomen, fullness of the abdomen, where a person says that there is a change in his stool habit or bowel habit. If he was used to going to clear his bowels in the morning once, he may be going 2 to 3 times. The consistency of the stool might change to semi-solid or liquid, which is called spurious diarrhea in medical term. Patient may feel that he is not able to pass flatus and he has to really struggle hard to pass a stool, and there is an incomplete evacuation of the stool. Sometimes patient may present as anemia because of the loss of blood in the stool. Sometimes the loss of blood in the stool is so minuscule that it is not visible by naked eye. It can only be tested by some special tests. So patient will present with anemia. The cancer of the right side of the colon normally would present with anemia, and cancer of the left side of the colon normally would present with obstructive symptoms like distension of the abdomen, inability to pass motion or gas. The commonest test which we need to do is a stool test for bleeding. It's called a stool for occult blood. This is a test, a specialized test, which will diagnose even the microscopic blood in the stool. As I said before, whenever you find blood in the stool, we need to rule out so many causes, and cancer is one of them. And we need to then proceed to colonoscopy. Colonoscopy is a special investigation in which an endoscope, a flexible, thin, tube-like structure, is passed through the anus to look into the inside of the large intestine, colon and rectum. The advantage is that we can see at the disease with our own eyes, and also we can take some biopsies from this disease. Now let's look at some tests which will stage the cancer or the disease. The first I would like to mention is a CT scan. A contrast CT scan of the whole abdomen is one of the most important investigations to stage the colon cancer. What it does, it tells you the minute details of the abdominal organs, liver, lymph nodes, blood vessels, and if the tumor has spread beyond the stage, beyond the inner lining of the colon to outside in the abdomen. This is an essential investigation before we plan a treatment for these patients. The next, I would say, in a special investigation is MRI, magnetic resonance imaging. This is also a very important investigation, especially when the cancer is in the rectum. It indicates the anatomy and also tells us that in what stage the tumor is, which wall of the rectum tumor is there, because that will determine what kind of treatment are we going to offer to the patient. Ultrasound. This is a very, very sophisticated investigation in which there is an ultrasound probe attached to the colonoscope, and it measures the depth of invasion of tumor into the rectal wall or the colonic wall. Again, as I said, this will determine what kind of treatment are we going to offer patient first. Another special test in this line is PET scan. PET scan is done to see if there is tumor spread to other organ other than colon or rectum. Now let's look at the staging of the cancer, colon cancer, because that is a very important part which will determine the treatment. We normally have 4 stages of colon or rectal cancer. The cancer, when it is confined to the inner lining of the colon or rectum, is called stage 1 disease. When it goes beyond the inner lining into the muscle layer of the colon or rectum, is called stage 2. When it involves the outermost lining of the colon or rectum, is called stage 3. When the tumor goes beyond the outer lining of this organ and involves the adjacent structures or goes to the distant organs, is called stage 4. Stage 4, when it involves the distant structures, is also known as metastasis. Metastasis is breaking away of the tumor cell from the original organ and going to different organs. For the purpose of treatment, we will divide our discussion to 2 parts: cancer of the colon and the cancer of rectum. First, coming to the cancer of the colon. Surgery is the mainstay of treatment for most of the colon cancer, in which we remove the part of the large intestine, colon, which is bearing the tumor, and also on the both sides we remove normal tissue. Depending upon the site of the tumor, it can range from 5 to 10 centimeter of the normal colon along with the tumor bearing area of the colon. Taking away that portion of the colon, we also remove the lymph nodes. Lymph nodes are the small nodes which are present in the surrounding area from where the blood supply of the colon is coming, because they may harbor cancer cell as well. That is why the lymph node is also removed along with the tumor bearing area. After removing this area, now we need to join both the ends together and sew them. It is called anastomosis. Joining 2 ends of the intestine is known as anastomosis. In most of the cases where surgery has been done in a planned way, we are able to anastomose 2 ends of the intestine. However, in certain cases where there is a lot of swelling in the intestine, or the surgery was done in emergency because of bleeding or because of acute obstruction, in those cases we may not be able to join 2 ends of the colon together. In this case, we need to bring out the portion of the colon to the abdominal wall, which is called an stoma. A plastic bag is fitted onto the stoma, so stool can be collected into that bag and can be emptied frequently. This is called colostomy or stoma. Once the patient recovers from the surgery and patient is doing well, then we can close this stoma after 6 to 8 weeks and rejoin the 2 ends of the intestine, which is called anastomosis, as we discussed. Then we send that piece of the tissue which we have removed for biopsy, histopathology as we call it in our medical language. What histopathologist does, cuts minute sections of the specimen and in hundreds of number, and it looks into those sections under microscope after doing special staining. The purpose of doing this is to confirm the diagnosis of cancer and also see what are the types of the cancer this intestine bears. It can be well differentiated, moderately differentiated, or poorly differentiated. Depending upon the biopsy, and also a histopathologist looks at how many lymph nodes harbor cancer cells. And that is how we will come to know the exact staging of the tumor. If it is stage 1 and 2, nothing else needs to be done. But in stage 3, most of the time, chemotherapy will be advised. Now let's come to carcinoma of the rectum. It's slightly different than colon cancer because in carcinoma of the rectum, the late stage 2 onwards, the radiation therapy should be given before operation because it reduces the size of the tumor. As you know, pelvis is a very narrow organ, and also there are very important structures around like urinary bladder, seminal vesicles, prostate, ovaries. So we do not want those structures to be damaged or tumor involving those structures. So first we give course of radiation to these patients to constrict or shrink the tumor, and then wait for 4 to 6 weeks before we take them up for surgery. Rectum is also divided into 3 parts: upper rectum, middle rectum, and lower rectum. The tumor in the upper and the middle rectum are clearly excised along with the fat around the rectum and the lymph nodes, and the two ends are joined together as we were discussing in the colon cancer, making a colorectal anastomosis. However, when the cancer is in the lower part of the rectum, sometimes it is not possible to save the anal sphincter complex. That means we cannot create a normal passage for the stool as it was existing before. In this situation, we completely close the anal opening and we bring out the stoma from the left side of the abdomen, which is known as a permanent colostomy. In a lot of cases of low rectal cancer, to save the sphincter with the help of imaging, radiation, and new technology in surgery. So after we remove the cancer bearing area of the lower rectum, we still can join the two ends together. But since the blood supply of the lower rectum may not be as good as we want for the healing, we still would like to give a temporary stoma to the patient in the right side of the abdomen, which is known as ileostomy. We bring out the small intestine outside, but this is a temporary procedure. After patient completely heals from the surgery, 6 to 8 weeks later, we can close this stoma and patient can now pass stools from its normal passage.